All right, everybody. Inflammatory bowel disease. We're going to look at it. This is going to be really important. This is going to be very detailed. So I want you to really pay attention to what you're seeing on this particular one. If you look here, there's a healthy colon up here in the picture. And then this one is ulcerative colitis. Do you see it looks like a big red bleed, like a big red ulcer? And then we've got Crohn's disease, and they've got like a little cobblestone appearance. That's really what it looks like inside of the colon. And as you scope down, you'll see these little things right here, these little red, darker red areas. They'll bleed. They'll be oozing blood. Um, Very, very painful for both of these. Most of these diseases are called autoimmune disorders, where for some reason, we don't know why the body wants to attack parts of the colon. And so what will happen is white blood cells will come in and start attacking part of the colon, and it's only in the colon that they're doing it, and we don't really understand why. So patients with these types of diseases sometimes will go through exacerbations and remissions. But if you look, let's go here. What would be some labs you are going to look at for both types of diseases? Okay, so let's just look and see. Because there's bleeding involved in both of these, the hemoglobin and hematocrit would be low. Because both of these diseases have white blood cells coming in and attacking the colon, their inflammatory markers are going to be up. Their erythrocyte sedimentation rate, their ESR is high. Their CRP, which is creatinine react something, I can't remember, but you know what I usually call it? Crap in the blood. Sorry, excuse me. But that is an inflammatory marker. I think it's C-reactive protein. And then your albumin would be down because your protein is just low. You're not getting the nutrients that you need, and you're probably having some electrolyte imbalances. How many of you guys realize that with some of these colon issues, you would have electrolyte imbalances because of all of the things that are going on? So you got to know your normal values. I would go back and know normal ESR, normal CRP, hemoglobin and hematocrit. But know that these go up when there's inflammation in the colon or wherever in the body. These are not colon specific right here. And then our albumin is about the same as the potassium levels, which 3.5 to 5.5. It just adds another point there. And here's all of our electrolytes. You better pay attention to them and try to remember them, because I don't think they're going to be listed on your test so that you can see if they're in normal range. So you're going to have to decide that, right? So before we go into this, let's go to this picture here. And what you're going to see is, this is just a drawing, but it's an ulceration of the colon, and it looks like a big ulcer. That's how I look at it. And then you got the cobblestone appearance that's inside the colon. I certainly like the real picture better. But when you're looking at the inflammatory bowel disease, you're going to have to look specifically at certain areas for Crohn's disease. And I'm going to tell you exactly what side of the body you need to look at. So when you have ulcerative colitis, remember the one that looks like a big open red sore all the way around the colon? This is on the lower left side, or the descending colon. So when we scope in there, we would look at the rectum and maybe this sigmoid area and this descending colon, and it would be bright red, bleed, look like a big raw open wound. And remember, with this big raw open wound, that tissue has changed and has thinned out. And it's a possibility that you could have a rupture there. It's a very serious thing, and it's very painful for the patient who has to go through the bathroom and stool has to pass through this. So this ulcerative colitis is on the lower left. I know in the picture it's backwards, but lower left quadrant. Now, Crohn's disease is a little bit different. Crohn's disease has the cobblestone appearance. Technically, you could see it. You could see it throughout the colon, but for your exam and for the boards, you have to know lower right quadrant. And really, if a patient will usually complain lower right quadrant. Crohn's can affect this little last part of the small intestine here and the cecum, and this ascending colon right here. So that's why we say Crohn's is the lower right, ulcerative colitis is the lower left. Please, please, please remember that. Okay, so if you look, you got to know what cobblestone appearance is, which we saw in the picture, and that those little cobblestones kind of have, they weep blood. Um, it's just kind of weepy. I don't know another word for it, or ooze blood, right? They have certain, so what I would do is I would take a picture of the lower right quadrant, and I would say, this is Crohn's, and I would say they have pain unrelieved by defecation. So when they go to the bathroom, they still have pain. They are more crampy after meals, unwilling to eat. They have right lower quadrant pain, which is very important. Tenderness and spasms, because they feel like this is so bothersome, they just don't want to eat. Um, and in fact, a little young gal the other day, when I saw her, she said she was having some problems. She says, I just don't want to eat. I can't eat. So she may have something like this going on. Occult blood, because higher up in the intestine, which means that the blood may be hidden. If you do an occult blood test, that means you can't see the blood, but they can detect it if they do a test. They have a lot of fatty stool. Steatorrhea is the name of it. So, that's interesting. Crohn's disease. Dehydration, because, it's affecting the colon's job. One of the colon's jobs is to pull water back into the body. And so the bun might be up because of the lack of fluid going back into the body, and potassium would be down. And they might lose some weight because they just simply aren't eating. Intestinal obstruction, because of narrowing, like we said, once that tissue changes and the white blood cells are coming in and make the tissue different, it tends to narrow, and then they start having stricture formation, a little more narrow, perianal disease, fistulas can tunnel, and then abscess formation. Okay, so pay attention to this for Crohn's for sure. Look at Crohn's disease. I like this. Crohn's tends to run in families. We're not going to say it's necessarily genetic, but it does. Maybe the way that the bowel wall and the white blood cells attacking it. I don't know. Usually the ages that you will see this in a patient is between ages 15 and 40. We consider it an autoimmune disorder because of the way that the white blood cells are attacking the body. And then nausea and vomiting would be something you would see, and not wanting to eat. They will have abdominal pain and distension in the right lower quadrant. And we watch for dehydration, electrolyte imbalance, and even some anemia because they're bleeding, right? So here's the thing. If your patient, say for instance, you go to your general doctor and you're just getting a yearly checkup, and they run some labs and they say, ooh, your hemoglobin and hematocrit are low. What doctor would they send you to? They're going to send you to a GI doctor because you have a bleed somewhere and you may not know it. So usually it will show up as low hemoglobin hematocrit, some anemia in the patient, severe diarrhea, low-grade fever, bloody stools, weight loss, severe malabsorption, and look, some complications. Peritonitis is one of them. Abscess, fistulas, which is like a little tunneling in the colon anytime that tissue changes shape. So we got to really understand what Crohn's disease and where it's at. And then if we have ulcerative colitis, I want you to think like a big ulcer. Skin discrimination of the lining, which just does mean the whole lining. Ulcers on ulcers. It's just horrible, right? This person will have severe diarrhea, 6 stools plus a day, passage of mucus and pus, left lower quadrant pain, and then rectal bleeding. You're going to see bright red rectal bleeding with ulcerative colitis. That's different, right? And then this one is called tetanus, or cramping rectal pain. They feel like their rectum is hurting. So be aware that this rectal pain, this tetanus, you may need to know that tetanus. Visible blood, you're going to see it. You will be able to see this. Weight loss, probably. Dehydration. Toxic megacolon. Now, here's my thing on this. Toxic megacolon happens when the tissue in the colon changes. And earlier in a video, I talked about, let's just see if we can go back to it. Right here, you don't see it, but these nice little hosta pouches, they're supposed to be there. But with ulcerative colitis, what will happen is this whole area is so raw and inflamed that the hosta pouches lose their shape and they balloon out. And it's called toxic megacolon, because at that point, when this whole tissue balloons out, the bacteria that's in the colon can now transfer through the tissue out into the peritoneal cavity. Now we got a big problem, and it's called toxic megacolon. Okay, so just know what that is. Perforation, bleeding a lot, anemia, colonic distension. What are you going to do? You're going to rest the bowel, NG tube, IV fluids, and possibly take out the colon. Now, here's the thing. They come up with some really good IV medication treatments that will help the patient. And so be aware that there's some new treatments out there to help with these. I used to give Entyvio infusions, and what Entyvio does is it holds back the white blood cells from attacking the colon. But you know what? We're not just holding white blood cells back from attacking the colon, we're holding white blood cells back in the whole body. So the person's really at risk for infection, and a bunch of little other diseases because they're taking that treatment. When we have inflammation in the bowel, no matter what it is, how do we manage it? Well, here's what we're going to look at. We're going to look at normal elimination patterns and helping relieve pain, maintaining fluid. If they need nutrition, they might have to be on TPN, promoting rest, preventing skin breakdown. What are the complications, right? Self-care teaching. What are we going to do? No cold foods, no smoking, a low residue diet if they have a flare. It's called a hot belly. They need a low residue diet, not a lot of fiber or anything, just very low residue. Decrease inflammation is our goal. Low residue diet, increase calories, increase protein, no fruits and vegetables, because guess what? They're fiber, right? So make sure you know that if you have one of these diseases, we're going to do low residue diet. We want to increase calories, so this person may do protein drinks or something to help increase their protein. A lot of times the doctor for these kind of diseases will prescribe some type of a corticosteroid to help with inflammation. There's different kinds that you can prescribe. If diarrhea, no milk, no cold foods, no spicy foods. See how this is a little complicated? You would definitely avoid high fiber. You don't want to give high fiber to a colon that's already very, distressed. So no whole wheat, cereals, nuts, seeds, raw, dried fruits and vegetables, grains, grits, oatmeal. Those are high fibers. You can do canned or cooked veggies, which is they're softer, and asparagus tips. If anything's canned, it's probably going to be okay. Potatoes. No skin, pasta, noodles, white rice. Those are things that we can eat with inflammatory bowel disease. So let's look. Okay, so we're going to go to our book here. Inflammatory bowel disease, is a chronic inflammation of the GI tract with, it says characterized by periods of remission with exasperation. Just means periods of really bad time, and then it goes away for a little bit. We classify irritable bowel as either Crohn's or ulcerative colitis. And this is where people get mixed up on the test. They get I said irritable bowel, didn't I? And see, I'm confusing you. This is called inflammatory bowel disease. Inflammatory. There is something else called irritable bowel, and that is where they can't find anything wrong. So when you see inflammatory bowel disease, you've got one of two things: Crohn's or ulcerative colitis. Sorry, I messed up on that. You know how easy it is? That's how easy it is to mess up on that. So you got to pay attention. Is this inflammatory bowel or is this irritable bowel? Okay. And remember, ulcerative colitis and Crohn's, what sides of the body are they on? And it says about 1.3 million Americans have inflammatory bowel disease. It often begins during the teenage years and early adulthood. Inflammatory bowel has a second peak in the 6th decade of life. So yeah, when you're 60 in that area. It's interesting. It says the highest rates are in the northern hemisphere and the industrialized nations. The risk for having this is greater in urban compared to rural areas. And look, and those of white and Ashkenazic Jewish origin. I probably butchered that. Sorry about that. The strongest risk for factor is family history. So many people with irritable bowel have a family member with the disorder. I don't know. Yeah. We do not know the exact cause of inflammatory bowel, but it is an autoimmune disease involving an immune reaction to the person's own intestinal tract. So that's very important. Look at some of the factors such as diet, smoking, stress, increased susceptibility by changing the environment of the GI microbial flora. You know, inside your GI tract, you have this beautiful world, this ecosystem of microbial flora. And when we take antibiotics, we change that flora. When we smoke, we change that flora. Our diet can change that flora. So, I mean, things can happen, right? We think that dietary factors unique to this industrialized countries contribute to the development of inflammatory bowel, like our high intake of sugar and fats and polysaturated fats and omega-6 fatty acids is associated with this inflammatory bowel. Eating fewer raw fruits, vegetables, omega-3 rich foods, and dietary fiber decrease the risk. It's funny how it just said, oh, omega-6 and then omega-3 here. So you want to eat fewer raw fruits and vegetables. Oh, omega-3 foods and dietary fiber decrease the risk. Okay, let's look at this. We said there's a genetic link, but it says we have found over 200 genes associated with inflammatory bowel disease. They don't really know, right? But if we look down here, this will be a very good box. I'm sure that your instructor probably gave you this box. And what I would look at is maybe what does the abdominal pain look like, right? Diarrhea is common in both of them. Fever could be common. We want to pick out something that would be different. Do you remember how I said tinnitus is rectal pain? It's rare in Crohn's disease because Crohn's is not even near the rectum, and it's common in ulcerative colitis. Weight loss is rare in ulcerative colitis, but it may be common in Crohn's. That's kind of different. And then cobblestone appearance is going to be very common in Crohn's disease. And you can see it when you go in and scope somebody, but they're not going to have it in ulcerative colitis, or it's very rare. If you notice, it says the depth of involvement. So if you look here, it says the mucosal layer for ulcerative colitis is that mucosal layer that's really raw and red. But the whole thickness of the bowel with Crohn's disease is involved. That's kind of crazy, huh? Let's look down here. I want to see cancer, okay? Increased incidence of colorectal cancer after 10 years of the disease. That's with the ulcerative colitis. Increased incidence of small intestinal cancer, increased incidence of colorectal cancer, but less with ulcerative colitis. So ulcerative colitis has a higher risk of cancer with it. C. diff, it says increased incidence and severity. Perforation, okay, now I want you to look here. Common because of toxic megacolon in ulcerative colitis, but it's also common because of the inflammation of the entire bowel wall and the other. So we're really going to have to look at these two things. We're really going to have to investigate what is different, what's the same. Be aware, draw it out on a piece of paper if you have to. And then strictures, which means tightening of the colon, common, occasional, and then toxic megacolon is more in ulcerative colitis. So that chart might be really important for you to look at, okay? And it just says the difference between Crohn's and UC. And just know we have got, with Crohn's, it's called skip lesions or cobblestone appearance. The inflammation in Crohn's disease involves all layers of the bowel wall. Typically, ulcerations are deep, longitudinal, and penetrate between the islands of inflamed edematous mucosa, causing the classic cobblestone appearance. Strictures at the areas of inflammation can cause bowel obstruction. Yeah, it sure can. So Crohn's is that cobblestone appearance, right? So pay attention. Crohn's is usually on the lower right, and ulcerative colitis is on the lower left. Know what they look like. Know the difference. Um, Pay attention to that chart, okay? And know that the bowel actually, let's see, okay, we don't need to go there. This is not what we need. So if you look, ulcerative colitis usually starts in the rectum and moves in a continual fashion towards the cecum. So it kind of works its way backwards through the colon. Although mild inflammation may occur in the terminal ileum, ulcerative colitis is a disease of the colon and the rectum. So it's more on the left lower quadrant. The inflammation and ulcerations occur in the mucosal layer, the innermost layer of the bowel wall. So I would just remember that. Let's see. Make sure, to me, I would create my notes on this because you don't want to get confused on the test. Just like I got confused with irritable bowel syndrome or inflammatory bowel. These two are inflammatory bowel diseases. Okay, so we have a question. This is ulcerative colitis question, and this is going to help you. I think some of these U-World questions are good for ulcerative colitis and Crohn's disease, so we'll look at a couple of them. The nurse is planning care for a client who is experiencing an acute exacerbation of ulcerative colitis. So in your mind, you got to think, what does it look like? Where is it? Which of the following interventions should the nurse include in the client's plan of care? Select all that apply. Now, here's where you're going to see if you know it or not. I want you to just stop the recording and look at all your answer choices and then restart your recording. Okay, so hopefully these are the choices that you chose. Let's look at them together. Administer prescribed analgesics as needed. Yeah, it's going to be bright red, raw, like a big ulcer. We're going to need pain meds. Initiate hourly monitoring of intake and output. Yes, it does affect the fluids in our body, right? Offer the client cold foods during meals and snacks. I don't think so. I think there was something about foods in cold foods. And then assess the client's compliance with the medication regime. Yeah, they need to be compliant with their medicines. Sometimes they're steroids, sometimes they're infusions. Encourage the client to discuss feelings about the condition. Yeah, you would do that. Let's look and see, hopefully. It shows a little bit of ulcerative colitis here with a little polyp. I'm not really liking that picture too much. But if you look here, ulcerative colitis is a chronic inflammatory bowel disease characterized by inflammation and ulceration of the large intestine. And you guys know it's on the lower left quadrant. Our big goal is manage pain, give them fluids. They're going to have diarrhea, poor intake, and all sorts of things like that. And then they need to adhere to their medications, whatever the doctor prescribes for them. So that would be important. And let's see if there's anything else here. We are also going to address their psychosocial needs because guess what? When you have this, it's very depressing. People will feel hopeless, depressed. You know what? It may be your neighbor that has this. People don't often talk about that they have colon diseases. It's embarrassing. So we're going to encourage them to discuss their feelings. Clients with UC should avoid cold foods, which can increase intestinal motility. Whew, you know what? I didn't even know that. So cold foods can increase intestinal motility. In addition, clients should be instructed to avoid trigger foods like nuts, legumes, alcohol, caffeine, and fatty foods. I don't think caffeine's ever good for anything. But let's go on to the next question. Okay, once again, I have an ulcerative colitis question. The nurse has taught a client with ulcerative colitis who's receiving prednisone, there's your steroid. Which of the following statements by the client would indicate a correct understanding of the teaching? So we are going to teach a client who has ulcerative colitis, and it says which would indicate a correct understanding of the teaching. Pause your video, look at your answers, and then we'll answer. All right, so the nurses taught that client with ulcerative colitis. I hope you picked the same things that are the correct choice. I should consume a low-calorie, low-protein diet. No, remember, we said they need a high-calorie, high-protein diet. I will participate in a smoking cessation program. Yes, smoking can, affect this. I should increase my daily fluid intake when I have diarrhea. Of course, we don't want to lose any more fluids. I will keep a journal to record what I eat and drink during the day. Yes, I should avoid taking vitamins and supplements containing calcium. I don't see any reason why. Let's go down here and let's look. Let's see if we can find this. Here it says, avoid tobacco, caffeine, alcohol, which are gastric irritants that stimulate the intestines. Increase fluid intake during episodes of diarrhea. Oral hydration is critical because clients may have greater than 10 stools a day during episodes. Wow, that's a lot, right? Keep a diet journal to help identify triggers. Triggers vary greatly among individuals. So whatever food, we got to know what triggers your information. Here's another one. This is a common drug that you would see. This is an ulcerative colitis question. And it says a nurse is teaching a client with ulcerative colitis who has a new prescription for sulfasalazine. Now, sulfasalazine is an anti-inflammatory. I think it's kind of a chemo drug. Which of the following information should the nurse include? So what I want you to do is pause and say, we got ulcerative colitis with a new prescription for sulfasalazine, really for inflammation. And then what are you going to include? Okay, so hopefully you pick 2, 3, 4, and 5 because those are correct. Remember, avoid consuming foods high in protein. You need the protein. Take vitamin and mineral supplements daily. Yes, we need the minerals and the vitamins. We can apply a barrier skin cream in that perianal area for the irritation. We can do that. Increase your daily fluid intake to at least 2,000 mils. I think I saw that on my notes. Continue taking sulfasalazine after your symptoms have resolved. Yes, this is a medicine that you would have to continue to take even when you don't have times of, trouble. So be aware of that. If we go down here, it just says use skin barrier cream. We could use witch hazel or sitz bath or, just to prevent skin breakdown. And then we want to maintain a well-balanced diet, 2,000 to 3,000 mils of fluid daily, and helps with hydration and electrolyte balance. We got to have vitamin and mineral here daily to replenish those lost from the diarrhea and the malabsorption. And then it says take prescribed sulfasalazine. Okay, it is a 5-aminosalicylic acid derivative. I think it is actually used in chemotherapy, but I don't know. After symptoms subside to prevent relapse. Those are just important things. So hopefully that one is helpful. Okay, now we're moving on to diverticulitis. Oh, y'all gonna get this right. I can feel it. The nurse is caring for a client with acute diverticulitis who has nausea, vomiting, and rates their pain on a 0 to 8 scale. Hey, we don't need this one. We just did this one on the last one. All right, give me a minute. Let me go find another one. Well, we'll just leave my little mistake in there. You got to have something to laugh about. So this one is actually an ulcerative colitis one. The UWorld offers a lot of ulcerative colitis questions. That must be important. The registered nurse is developing a nursing care plan for a client who has just undergone surgery for treatment of ulcerative colitis, with the creation of a permanent ileostomy. What is the priority outcome for this patient? Now remember, this is a permanent ileostomy, and so what it is an opening into the small intestine where the stool is really liquidy. So go ahead, make your choice. Well, here's your answer, and I remember your instructor saying this. the client will look at and touch the stoma, right? Remember, some people who undergo ostomy surgery must become independent in care. They've got to be able to handle it. This requires adaptation to a significant alteration in the body image and dealing with a number of psychosocial issues that are associated with it. It is not uncommon for a client to cope with this loss by refusing to look at or participate in the care of the stoma. It's scary. So, how do we know that they're, handling this well? Is that they'll look at their stoma. And what would be your priority outcome would be out of these choices to look at the stoma, and that tells us that the patient is improving. Let's look here. It says this is an appropriate outcome. Community organizations can offer support and educational materials to the client. However, it's not the priority. This is an appropriate outcome, but has a passive activity. It is not a strong indicator that the client is ready for self-care. And then 4 is this is an appropriate outcome as it indicates effective ostomy teaching. However, it's not the priority. That was a tricky one because you want to pick something else. They're all appropriate, but what would be most important is that the patient can handle it themselves and see it and acknowledge it. Well, I have tried to find a Crohn's disease question, and I don't find one here in the UWorld content that I have. But go to the Evolve, the Saunders NCLEX book, and look up inflammatory bowel disease, and you probably will see some Crohn's disease questions in there. I hope this was helpful to you, and I hope you know that this one is going to be pretty tricky, so you're going to have to know the difference in what you're looking at. So pay attention to go over the content and look at each one individually and know what side of the body they're on, know exactly what what you're looking at when you get into this. Let's go back here real quick and just make sure you know. This is really helpful. Know what ulcerative colitis looks like, where it exists. Know what Crohn's looks like, where it exists in the body. Know your labs, okay? I know labs were going to be really important, but no, they're going to bleed on these, right? And don't get it confused like I did. Inflammatory bowel disease is different than irritable bowel, right? So I hope you all have a fun time studying.